All right. Well, thank you so much for joining us today. The pain section and our sort of stakeholder analysis for the trigeminal guidelines that we're putting together. Today, we are so fortunate to have Dr. Soni from the Cleveland Clinic, who is a headache neurologist, and she'll introduce herself even more to help us work through the neurology side of our thoughts about the trigeminal guideline PICOs that we've been working on. I am David Darrow. I'm a pain and functional neurosurgeon at the University of Minnesota.
Hi, so I'm Payal Soni. I'm a neurologist and a headache specialist at Cleveland Clinic. I'm also the medical director of our trigeminal neuralgia service line. So I see a lot of TN patients, a lot of not TN patients as well. So I think that's something that we're going to be talking about a little bit more.
I'm Sharona Ben-Haim, functional neurosurgeon at UC San Diego. Also have a large facial pain practice and also part of the pain section. So really excited to be having this conversation with you.
And I'm Vishad Sukul, functional and pain neurosurgeon at Westchester Medical Center in New York. And I deal with a lot of atypical facial pain and neuromodulation for facial pain as well.
So I think we would love to hear, Dr. Soni, about, even a little bit more about you and how you got steered towards headache and facial pain, because neurologists can choose a lot of different fields these days. So what pointed you in that direction?
Yeah, sure. So I started my neurology residency a little bit undifferentiated when it came to subspecialty. Was kind of open. I really enjoyed a lot of my headache clinic rotations, and sometimes that kind of comes as a surprise, I think, to a lot of my co-residents, because pain patients often can be very draining. That's not the most exciting thing. And when you get that ER consult for somebody with a headache in the middle of the night, it's not always very exciting. But what I really enjoyed about the practice was the patient relationships that I was able to form, I think, and being able to really make like a tangible difference in a patient's life for an illness that can often seem very invisible. You look at them, they look okay, they can walk okay, they can talk okay, but pain is significantly debilitating. So to be able to kind of offer treatment options, offer a line of support was really rewarding. For me. And then trigeminal neuralgia in particular, I got interested during fellowship. I started seeing more patients with TN. I got interested in the pathophysiology behind it. I enjoyed the management options. I enjoyed the different types of procedural options. And I also really enjoyed working with my neurosurgery colleagues, actually. That was kind of a few years ago when I was in fellowship, was the beginning of our service line formation. So we were really in talks of how can we better care for these patients. I'm sure you've seen patients that had bounced around from doctor to doctor, been diagnosed and misdiagnosed, had a procedure, been on different meds with nothing helping. And by the time they finally get to the right person, they've spent so long in disability. So I think that was something we really wanted to really bridge that gap and be able to get quality access, effective care to these patients in a fast way. So that was really what kind of led to the development of our service line and what we've kind of worked to grow over the last few years.
That's amazing. I think, so many of those things resonate with me, why I like doing pain in general. And, just the difficulty of being a patient with facial pain. I think that's one of the toughest diagnoses to have, because, by the time they get to us, usually they've had all their teeth removed. They've already had several procedures that really didn't help with either diagnosis or treatment. And the hard part is I often see them put on just the weirdest medication cocktails, that are just even hard to interpret what's going on. So it's one of those areas where it's like, I think the challenge is it's so interdisciplinary between dentists and neurologists and neurosurgeons and even a lot of pain anesthesiologists, are seeing these patients all the time. So I think it's almost the standard to get lost in the cracks.
Yeah, I definitely agree on my end in terms of, seeing patients with trigeminal neuralgia, atypical facial pain, trigeminal neuropathies. It's just sort of the gamut of facial pain. It's almost like you have to do the patient a solid service. You almost have to start from scratch every time, especially when they have these long, complex histories and have had multiple treatments done already, or even just complex medical regimens, right? Just sort of figuring out. So like a big question that I have, even though it's not necessarily something that we address specifically in the PICOs that we're looking at for the guidelines, is how you approach the diagnosis aspect of facial pain, in general.
Yeah, no, that's a good question. And I think maybe you were mentioning before, when you're coming in, especially when it's a patient that maybe has had a lot of evaluations. I try not to bias myself into what I've been, or what I read in the chart, or even bias myself to what the patient has been told that they have, because many people will come in convinced that they have trigeminal neuralgia because that's what they've been told by so many people, and then we hear a bit more about them, and I'm like, I don't think you have trigeminal neuralgia. That's why none of these trigeminal neuralgia treatments have been helping you. But really, right now, what we really rely on is a clinical diagnosis. So we don't have really physiologic biomarkers, radiologic biomarkers that we use to diagnose trigeminal neuralgia. It's a clinical diagnosis. But what I always like to tell my residents too is that not all pain in the face is TN. Just because you have facial pain doesn't mean you have trigeminal neuralgia. And trigeminal neuralgia is a very specific condition. So I have a kind of a systematic approach to history taking for these patients. When did their pain start? What does their pain feel like? How long does it last? What are their triggers? Is it intermittent? Is it continuous? So really to help kind of tease out, are they fitting that classical trigeminal neuralgia picture, or do they have atypical features? And if they have atypical features, that's when there's that kind of red flag kind of popping up. Is there something else going on? And from my experience and kind of some of the literature, I think we know a lot of these procedures that we do for patients for TN, usually outcomes are better when it's classical TN or a typical trigeminal neuralgia. So if it's an atypical presentation, I'm a bit more hesitant to refer to neurosurgery, or kind of, we want to make sure we're kind of exhausting all of our medical options first before we're moving on to something that's more invasive that may not have the best outcome for the patient.
Can I ask a quick question there? I think maybe the one of the things that is perhaps most divisive and really makes this whole field quite difficult is the language that people use to describe some of these presentations. And so I'd love to hear from you. Are you basing your definition strictly off of the ICHD3 diagnostic criteria, or do you go based on different criteria? I know neurosurgeons, we have our own criteria, the oromaxillofacial surgeons have their own criteria. And I think that we, the poor patients do get quite confused because, they get assigned one label and then another label. I personally refer to all patients in my clinic as just having facial pain. I try not to even use these specific terms and really just describe the symptoms. They can be so really just different for so many different people. So I'd love to hear your thoughts on that.
Yeah, you're right. And I think this is one of those pain points for me too, when I wish there was more standardization across the board so we all knew what everyone was talking about. So I try to I try to be as consistent with the ICHD 3 criteria, which has also kind of gone through its own iterations and changes. I think even in our electronic medical record, like the old terms are still in there. So you'll see lots of different things kind of piling up in the patient's chart. But I try to stick with the ICHD3 criteria. And then in our practice, we've encouraged kind of all of our entire headache center to make sure that we're documenting using those terms, and then also we kind of relayed these terms to our neurosurgery colleagues, so we're all kind of on the same page. I don't know if neurosurgery still uses TN type 1 and type 2 as well, which we don't use anymore, and I don't know, we actually never really use it. I think it was more of like a neurosurgery thing, but we try to kind of standardize it, at least in our institution, so we know exactly what we're talking about, and we follow the ICHD3.
I think kind of the bigger picture here is that for us to make real progress in this field and, in the research realm, it's really hard for us to even standardize outcome measures, across the literature currently, because everybody's using such disparate terms. Vishad and David, what about you two? What diagnoses do you guys use?
Yeah, we stick with ICH3 as well, and we mostly use that and try to be specific. I will say that over time we've learned that for the trigeminal autonomic cephalalgias, there's a lot more of a spectrum than there are as clustered as I think people have described. And so we're learning within our own population what that looks like, but it's always hard because the numbers are still small, even for a big center where we get a lot of referrals. And so I think, there's different utilities, right, to how we're talking about the diagnoses, right? For us, whether it's classical or idiopathic trigeminal neuralgia, it tells us a lot about treatment options immediately, right? And so we use that a lot. I'll say it takes quite a bit of effort to distill that to the residents, but they're using it more and more because, it helps us understand, or secondary trigeminal neuralgia, right, related to something else. It really changes how we think about treatment. Mm-hmm. But, that I think is, in some sense, in pretty stark contrast to what you were sort of referring to earlier, which is sort of the phenotype of trigeminal neuralgia. And that phenotype of trigeminal neuralgia can be across kind of a lot of actual pathophysiology. How about you, Vishad?
Yeah, I certainly agree. Like I said, I try to stick to the ICHD3, but then I often will default back to some of the more classic terminology, just depending on who you're talking to and things along those lines. For me, I think a lot of it is trying to parse out what is sort of that truly classic trigeminal neuralgia that's going to benefit from the more direct surgical therapies we have. And then, if they're not, then sort of figuring out like what I can offer, at least, right, from a neurosurgical perspective, or do we need to go back to the drawing board and plug the patient in with a good headache specialist to sort of help figure things out. And then sometimes I'm trying to sort of see, like, can I classify the actual headache syndrome for those patients where it clearly is not trigeminal neuralgia? Is it an autonomic cephalalgia? Are we looking at like a SUNCT or SUNA or something along those lines? So it gets a little muddied sometimes. But, definitely I agree with, what you guys have said, is that the nomenclature we use is tough. And the patients many times aren't entirely sure what to label things as. So, Sharona, I agree with you too. A lot of times I just like, all right, well, this is facial pain, and if I feel that this is like very clearly trigeminal neuralgia, I'll use that label. But if it's anything else, I'm like, okay, well, we're dealing with some sort of facial pain here. Now let's talk about like what we can do with regards to that, because there's just so much gray area. Yeah.
So one thing is that we work with a lot of dentists, and we've been trying more and more to understand their perspective from the temporal mandibular disorder side. How is that, how are you interfacing with that on the neurology side? Because it feels like there's a lot, TMD is such a big entity and so very common. How are you, handling that in terms of diagnosis? Because, they have sort of their own diagnostic process as well, I think, and they're actually doing a revision right now as well.
Mm-hmm. Yeah, I think TMD also, so many patients come in saying that they have temporomandibular dysfunction, they have TMJ pain, and how do you differentiate that from something that's really like a neuropathic pain or neuralgic pain? I think ultimately comes down, in my practice, it really comes down to the character of the pain, what and whether or not there are triggers. I think the tactile triggers that you see in a classical trigeminal neuralgia or secondary trigeminal neuralgia is really one of like the key points to diagnosis. In my mind, if you don't have tactile triggers, even if you have electric pain, I don't think you have trigeminal neuralgia, because of what we know about the nerve and how the nerve functions, and what we know about the studies that have been done looking at some of the more pathophysiologic changes in the nerve in these patients that do have neurovascular compression and things like that. So really like coming down to like history taking and what is affecting your pain, what makes your pain better, and what does your pain actually feel like. And sometimes I find like I have to ask the question in a few different ways without trying to lead the patient into giving me an answer that they think I want to hear. And it's hard. It's hard nowadays, right? Because patients have also done a lot of their own research and are familiar with some of these terms that we're asking. And I think also very strongly kind of want a diagnosis, which we may not always be able to give. But I do work closely with some of our dental colleagues when there is kind of that question of, well, how much is this contributing, and should we try to treat the TMD, and then once that's treated, see what's left, and if there's something left that still sounds TN like, then let's explore that further, but try to kind of peel away these other contributing factors.
And I think that's a great point. One thing that I find extremely helpful is a little bit of time with patients, and whether that's a medication trial or a few medication trials myself, and I can sort of see, how not only just how they're responding to the medications, but how they're thinking about the, relative trade-offs of, potentially a surgical treatment versus a medical treatment. That tells me so much more about where they're at and how, and so I think that's, recently I've seen patients who come into my clinic, they have very classic symptoms, but they've only had it for a few months. And I'm very hesitant to do anything for those patients, even when they have a lot of cognitive symptoms from medications, because it's just such a short amount of time that, in many ways, it's kind of like Parkinson's. You have to wait sort of a certain amount of time to make sure you're kind of in the right zone here, because you don't want to have a false positive and do a huge, a brain surgery on somebody if it's not really going to give them a durable result.
Mm-hmm. Yeah, and that's a good point, because you also think about, we see these patients that have MVD and do well, right? They're pain-free. I never see them back again. And then these patients that have pain recurrence, whether that's 1 year later, 5 years later, and then how much has happened in their other medical history. They're 5 years older. How are they going to tolerate meds, or what options do we have left at that point? So I always wonder, and something I always talk with my surgical colleagues about as well, is like, well, what is that like sweet spot? You don't want somebody to be too old that they're not a good surgical candidate, but too young that, they're 45 and they have pain recurrence and they're only 55 10 years later, and we've already done all of these options, and they still have 30 more years to to live. So where is that sweet spot, or how can we better identify these patients that are having pain recurrence? And is there a different way that we should be treating them?
And are there any, you talked a little bit about red flags. Are there some pretty clear red flags that really steer you away from, at least temporarily, like we got to put a stop to this process. We don't want to get you into surgery with these kind of symptoms because, you're likely not to get any benefit, or all harm, no benefit, sort of thing.
Mm-hmm. Yeah. So I think one of the biggest red flags, and you touched on this a little bit earlier, are things that suggest a different primary headache disorder. So usually pain in the face. The trigeminal autonomic cephalgia can do that, and can be in some senses very similar to that TN type sharp stabbing pain, though it's usually in the V1 distribution. So pain, a few red flags that will kind of have me take pause a little bit is pain that's only in V1, not V2, V3. If there's any autonomic symptoms associated with it. I talked a little bit about the lack of tactile triggers, not having tactile triggers. So those things are always kind of give me a little bit of pause. Bilateral symptoms also give me some pause that, okay, is there something else going on? Is there something else secondary, or is this another disorder that we're seeing? And then, lack of those classical, like if somebody says, I don't have any electric shocking pain, I only have tingling pain, and then sensory abnormalities. So kind of those red flags would be things that definitely give me pause, that make me think that, okay, this is not TN, maybe this is persistent idiopathic facial pain, or that former atypical facial pain, and the likelihood of you getting benefit from a procedure is low. So I really need to look at what are the other medical options that I can offer you before we really even go down that route.
Perfect. And one of our PICO questions is about imaging. Do you guys have, I'm sure you do, but do you guys have a standardized imaging where you can really see, all the high contrast features that we're typically looking for with neurovascular, interaction, and what would you say, to patients who are being evaluated, in terms of imaging, how picky should they be, in some sense? Because I have a lot of patients that, we up in Minnesota, we have patients that are in, North Dakota or way far away. And they're like, do I really need to come all the way to you to get imaging, to work this up? And my response is invariably yes, because we have spent so much time getting it just perfect, and we can see just absolutely everything, that I feel like it's probably 80% of the time, if they get an outside image, I'm going to have to repeat it,
Yeah. So my response is similar as well, especially if people are coming, many times we'll have people come to see us and they're seeing a neurologist and a surgeon at the same time, or on the same day, or for this joint evaluation. So if they don't have the right imaging, as you said, we've worked very hard to kind of tailor our imaging protocol so that way our surgeons have all the information that they need in order to make the best recommendation to the patient. And so we can say for sure, or as sure as we can within the limits of MRI, whether or not we think there's contact and or conflict, and the different options available to that patient. So yeah, I think that definitely makes a big difference. So certainly if I'm ordering imaging for the first time in a patient, we thankfully, I think, upgraded most of our MRIs to, so that they can do the Fiesta or the KISS sequences along with an MRA. But in the past, I used to be like, okay, you have to go to these specific locations to get trigeminal neuralgia imaging done. And that way I know that our radiologists are looking at it and it's being done the proper way. So yeah, I think that's really important.
And about half, or maybe slightly more than half of our questions that we're trying to get answered are really about the most standard things, comparing the different treatments, comparative effectiveness for the different treatments. And I feel like, in our world, I think we all have some like numbers that we quote, but there just hasn't ever, it's really hard to get a registry or some kind of tool big enough that we can just give people a chart and be like, this is what the durability looks like for these different procedures, and like some things matter and some things don't matter, and so I think there's a lot of regional variation. I'm learning as time goes on that there are very strong preferences for certain procedures when I have no idea if there's actually any difference between them, overall.
Yeah. And then also we have a very big MS population at our institute. So we see a lot of TN secondary to multiple sclerosis. And then what are the differences in managing those patients? On the medical side of things, there's not too many differences. We use the same meds, but I know on the procedural side there are, outcomes are different. And why is that? And are we basing this on appropriate numbers, or do we need to look at this a bit closer, for what we're offering for these patients? So yeah, I think in those cases of like secondary TN, that becomes really interesting to see, well, in this specific case, what is the durable benefit of these different procedures, and what should we do with the better option here?
So it sounds like these are good questions for us to be asking, so that we can have them answered, and so that they're at people's fingertips. Like, yes, there's clear evidence here, or there's not clear evidence, and we need to do more. And this is a good area for us to focus registries and research and things like that, because I feel like there's enough centers that are, good facial pain centers that do a lot of these procedures that we could probably populate a pretty big registry and sort of like, answer some questions here that just patients are always asking, and rightfully so. They want to know what are the stats here. For me, if I have MS, should I do a glycerol or should I do a radiofrequency? These kind of questions could be super helpful. Or if the answer is it doesn't matter, then it really frees people up to practice in sort of their best, in their best form, whatever they're most comfortable with. We have another PICO question that's really focused on medication weans after surgery. And we would love to hear sort of how you guys think about it. If there's any kind of biomarker diagnostic information that you're looking for there, or just how you're going about it from a safety perspective.
Yeah, so I think there really is no standardization for this, and something that hasn't really been studied or talked about enough for us to glean what is the best way to approach these patients. In our practice, we've kind of settled at like a continuing the medications the patient was on prior to the procedure. And then depending on what procedure they had done. So if they had microvascular decompression, where generally the pain relief is very quickly after the procedure, we'll usually see them in follow-up in the headache center about 3 to 4 weeks after, and then begin a medication wean. Unless there are some instances where patients are having significant side effects to medications that require a faster wean, we'll generally arrange, plan for that prior to the procedure, so the surgical team knows what to kind of discharge the patient on. But kind of arbitrarily, like 3 to 4 weeks has been the standard kind of follow-up that we've been doing. And then we generally will do a wean, just so we're not abruptly kind of discontinuing a medication, and making sure we're not seeing kind of pain recurrence as that wean is going. For patients that get Gamma Knife, it can take a bit longer to see that benefit. So usually we'll still keep oral medications on for about 2 to 3 months after the procedure, unless the patient, tells us, hey, I'm doing so much better, I want to start the wean earlier. But usually that's what I'm counseling patients, that we're not going to be making, significant medication changes soon after Gamma Knife, because it can take some time to really see the full effect of that procedure and to see that pain relief from that. So it varies depending on the procedure that they're doing. how the patient is tolerating the medication, how quickly they want to really come off the medication, and then how we can do that in a safe way as well.
On average, once you've started to wean medications, how long do you find that process takes? And I know that's kind of hard to quantify. But.
Yeah. So I would say, again, there's not really a standardized approach to weaning. I think it depends on, one, how many patients or how many medicines the patient is on. So, sometimes we'll have patients that are on 3 or 4 different meds for trigeminal neuralgia before their procedure. I like to do things one at a time, so take one medicine off at a time. So in those cases, things can be a little bit prolonged. If they're just on 1 or 2 meds, then it's generally relatively quick. Usually there's a dose reduction about every week until they're off by about half.
And occasionally, not very often, but occasionally I've seen some patients where, MVD goes great, they have a lot of compression, and we begin to wean the meds. But it seems like the MVD effect takes longer, it just sort of like settles in over time. And then eventually they're off the meds and they're pain-free. But there's just occasionally this 5 or 10% of patients that they just simmer out. And I haven't really seen that described, but I guess I haven't looked terribly hard for it. But it's always confusing because you wean the meds and they're actually still doing a lot better, but they're like, I don't know, I'm still, sensitive. And then so you just hold, and then eventually it takes.
Yeah. I know. I haven't found, I've seen that as well. And, I don't think I have as large numbers to make a generalization on my own, but which are these patients that are more sensitive that maybe we do need to do a slower wean on, and which ones, is there something, that we're seeing there? Is it these folks that have a ton of compression that really are just that nerve is taking longer to heal potentially? And so for those people, we need to go a bit slower. And are those potentially people that we need to, keep a closer eye on? Usually, sometimes my TN patients that have MVD and are pain-free, once they're off meds, they don't follow up with me. I don't see them again. We've been trying to do a 1 year, at least a 1 year phone call with one of our care coordinators to help with our registry, to help with our data collection, so we can kind of monitor these patients out. It's a lot of manual work for our care coordinators, but I think that's how we have to start gathering some of this data. And then, especially if we get out-of-state referrals, they're back home living their lives, doing their thing, which is great. But we don't get much follow-up on how they're doing. So.
Yeah, that's interesting to hear. And David, I agree with you that there's always that population of people who kind of definitely simmer out, right? Like they still are, they're better, but they're not quite pain-free right after surgery. And then it kind of, and I've always told patients, there's 3 buckets that you'll fall in after MVD. It'll either be perfect and you'll be pain-free immediately on waking up, or you'll be in this sort of category where it takes a little while to kick in. And then hopefully you're not in the category that doesn't respond at all. But I've never been able to really kind of parse out what the size of those buckets are. Right. And I agree with you. I don't feel like it's ever really been clearly reported in the literature, how that plays out. And I think, and a lot of patients, if they're doing well, they don't follow up. So I think we just don't get a lot of great information once they're weaned off medications. It's, sort of disappear into the ether. But that's a good thing. I mean, that you're doing well, and we don't necessarily want them to have to keep coming back to see us. But I agree from a sort of an understanding the clinical course over time, it does make it hard.
Yeah. And then I would add one more bucket to that, is those people that are pain-free, but then kind of have early pain recurrence, 6 months later, their pain's back, or, right. Where I'm like, well, why did that MVD pain relief only last a few months? We re-image, there's nothing else there. So most of the time, those people we're able to get under better control with medication and generally lower doses of meds, and they're fine. They're better than where they were before, but you don't get that complete relief.
I guess I can add, or as a follow-up to that is, since we're talking a little bit about recurrence, how do you approach recurrence in your practice? Because I think there's a lot, that's always the toughest thing for us as surgeons to deal with, because, I feel like if you fail MVD and it's classic trigeminal neuralgia, your options become more and more limited over time. How have you approached that in your practice?
Yeah, so, recurrence, I always, again, I want to make sure I'm not missing anything else going on. So they have pain recurrence. I'm kind of going back to, all right, let me take a bit of a, deeper history here. And what is this? Is this your TN pain recurring? Is this a post-procedural complication? Is this anesthesia dolorosa? Are you having paresthesias? Are you having some deafferentation type of pain, depending on the procedure that you had done, if you had gamma knife or radiation, or is this post-MVD pain? And is there something structural that we need to look at again? I would say that often ends up rarely being the case, that there is, something new structural going on, though most of the time I do re-image these patients. And then depending on their pain character, we'll kind of go back to, all right, the medical options. Is there a med that we need to retry? Do we need to go back on? Our clinic, we do a lot of Botox injections for trigeminal neuralgia as well. I think these patients that have had recurrence after procedure are often good candidates for Botox, given everything that they failed. They probably have failed, several medication options as well. So we'll kind of explore that opportunity with them too.
Yeah, that's great. That's become a bigger part of our practice before surgery for some patients as well. I guess getting it covered is, is a feat of strength. So if you guys have a big practice, kudos to you. You guys have figured it out. We're still learning, but we definitely have seen real big benefits from that.
Yeah.
Great. Well, thank you so much for joining us, Dr. Soni. We really appreciate your time. It's so good to have such a great perspective on the neurology side, on, trigeminal neuralgia and facial pain. Trying to bring everybody together is challenging, but I think it's super rewarding because we get to hear about a lot of the similarities, but also some of the differences in how we're sort of approaching things.
Yeah, no, thank you so much for inviting me. I think it's also incredibly inspiring to meet other people that are also kind of interested in working towards improving care for these patients. So I'm excited to continue working together.
Yeah,
Thank you
so much.